Good afternoon and welcome to our Thursday webinars. My name is Amy Gohl. I'm the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey. The partnership is providing today's program, Discussing Preterm Birth, Resources and Strategies to Use with Your Patients. A few pieces of housekeeping information before we get started. An hour after the webinar ends, you will receive an email with a link to a post-program evaluation. Please complete the survey to provide us with feedback on the program. To receive a certificate of completion, you must listen to the entire webinar and complete that survey. Certificates of completion will be sent via email within 1 week of today. This program is being recorded and will be available on the Partnership's YouTube channel until July 8th, 2022. All attendees' lines will be muted during the presentation, but we would like to hear from you. Please write questions in the question box, and our speaker will respond to as many as possible at the conclusion of her presentation. Today's speaker is Kaci Mial, who is the Education Coordinator for the Prematurity Prevention Initiative at the Partnership. In this role, she provides education on preterm birth prevention to healthcare professionals, community organizations, and consumers throughout Northern New Jersey. Kaci offers a wealth of experience, having been a reproductive health educator and researcher for the past 9 years. She received her bachelor's degree in psychology from Rutgers University and her master's of education with a concentration in human sexuality from Widener University in Chester, Pennsylvania. Welcome, Kaci.
Hi, everyone. Amy, thank you so much for that introduction. Welcome to the Partnership's Prematurity Prevention Initiative webinar discussing preterm birth. So today, what we will focus on are the disclosures, successful completion, learning outcome, an overview of the Prematurity Prevention Initiative. We're going to talk about why preterm birth in New Jersey is important, the racial disparities within maternal and child health, preterm birth in New Jersey, addressing the impact smoking can have on someone who is pregnant, and finally, I will discuss resources available to you through the Prematurity Prevention Initiative and what actions you can take with your patients when talking about preventing preterm birth. So I have no disclosures to make. Amy mentioned for successful completion to complete the online evaluation at the end. It will be emailed to you. And my hope for today is that by the end of this presentation, you all will be able to self-report an increase in knowledge related to preventing preterm birth and expressing an intent to change practice by including information or tools presented today in your everyday professional life. So a quick overview of the Prematurity Prevention Initiative. The Prematurity Prevention Initiative is one of the partnership's many programs. As Amy stated, I am the education coordinator for this initiative in Essex County. We work collaboratively with and are funded by Family Health Initiatives, whose focus is on Atlantic County and Southern New Jersey, while I conduct education in Essex County and Northern New Jersey. The Prematurity Prevention Initiative, or as we call it PPI, is a collaborative effort that focuses on interventions with great potential to reduce the number of babies in New Jersey born too soon. And we use data to inform the Prematurity Prevention Initiative's focuses, which in our hope will support the diverse landscape of mothers in New Jersey who experience prematurity. Given that Black and African American mothers deliver preterm at more than 1.5 times the rate of their white counterparts, strategies must be effective when viewed through the lens of equity. So why is this important? In New Jersey, the rates of preterm birth are high. Preterm birth impacts Black and African American communities at higher rates. Prevention intervention options exist to reduce the rates of preterm birth in New Jersey. And finally, we all have a role in preventing preterm birth. A large part of today's presentation is going to include messages that you can share with the patients or clients that you work with about why it's important to prevent preterm birth. So I'll give you a quick example. So many of the clients that I work with, toward the end of their pregnancy especially, usually the third trimester, I get, oh my goodness, get this baby out of me. I'm over it. I don't want to be pregnant anymore, right? And I laugh, not because this is funny, but because many of you may have heard the similar messages either from your patients, your clients, friends, or family. So one thing to remember if we hear this, these feelings are super valid, right? Because we don't know what that person has been through in their pregnancy thus far. We don't know how uncomfortable they're feeling or if there are other factors that make them feel like they want to give birth right now. However, we also know through research that waiting to give birth full term or at 39 to 40 weeks is beneficial to a baby's development. So the picture on this slide I chose because it's a screenshot of a handout I used from the CDC, or what I did use before COVID-19 when we were out in the community as a health educator. I was able to interact with the parents with using this sheet, and it really helps to illustrate some of the messages that we have to offer. And really the simple message boils down to, it's important to wait as long as you can as it's safe for you and baby to help them develop. So when a parent asks, why is it important to wait to give birth when baby is 39 weeks or full term? One explanation could be that the baby's brain, lungs, liver, etc. are still developing. So important developments occur during the last weeks of pregnancy. Babies need every week inside the womb as the brain, lungs, and liver are among the last organs to develop. And regardless of birth weight, babies born early are also more likely to be rehospitalized. That's why getting to full term is important when possible. Around week 35, the brain is only about 2/3 the size of a full-term baby's. Hearing is not fully developed until full term. Same with a baby's liver. It might not be mature enough to prevent jaundice until full term. When it comes to baby's body fat, they may need their temperature to be steady, and that might not be able to occur until week 37. Breathing, sucking, swallowing, all of these reflexes that are developing are also usually not ready until 34 weeks or later. So it's very important to think about these things and other issues that could occur, such as feeding or nutrition with the lungs, breathing, etc. When we think about preterm birth risk factors, the risk factors can really be broad. So a few of them here are some of the more common ones supported by research. Short time between pregnancies. When messaging, giving messaging to patients regarding this risk factor, it's likely going to include the discussion of birth spacing. So one message to pass on to your patients or clients is that it's recommended to wait at least 18 months to allow the body to heal prior to becoming pregnant again. For patients who are older than 35 or who have had a miscarriage or stillbirth, waiting 18 months might not be right for them. So as a health educator, what I do is encourage my clients in this case to ask their medical provider for the appropriate time to wait. And something else important to remember when discussing birth spacing is culture plays a huge role in the beliefs we have about how long to wait between pregnancies. So for example, you might have a patient who has a desire to have children that are in school together, or you may have somebody who has a faith-based belief that says, it's God's will when I will or will not get pregnant. So these are some of the messages that I've commonly heard in the community. You may hear others as well, but it's really important to try to learn to practice cultural humility so we're interacting with our patients and clients in a way that's most relatable to them. And we're also passing on accurate information and tools that they can use to make informed decisions. So with our next risk factor, talking about pregnancy history. When the maternal or expectant parent's previous medical history, it's important to know that has someone had a previous preterm birth before? If so, that can increase the risk for delivering prior to 37 weeks. Certain types of surgeries on the uterus, cervix, chronic health conditions can also increase someone's risk. And it's important both for patients and the medical provider to have access to the medical records and history to ensure you have the most updated information and can give the most accurate recommendations for prevention and intervention. With pregnancy complications, somebody who's having multiples, twins, triplets, vaginal bleeding, being diagnosed with a short cervix can also be factors to increase risk. Stress during pregnancy. This is a risk factor that I really try to stress or pay attention to and make sure that this message gets across both to clients I may be speaking to or providers in medical facilities or other educators, because not only are we talking about acute stress, we're talking about chronic stress, and also racism plays a huge role in the stress that somebody who's pregnant may experience. So the term weathering, we might hear, to quote an article by Patia Braithwaite, the term weathering describes how the constant stress of racism may lead to premature biological aging and poor health outcomes for Black people. Like this, so for example, disproportionately high death rates from chronic conditions such as heart disease, stroke, diabetes, and most cancers can also be impacted by stress, racism, and weathering. Our last two listed here, late or absence of prenatal care and lifestyle factors. Really important to include these either in a preconception appointment or talking about once they do get to prenatal care, what are some factors that can be modified or adjusted throughout or before pregnancy. When we look at this slide, here's a photo of pregnancy anatomy. It points out where the uterus, the cervix, the vagina is, and this may be review for many of you if you're a medical provider. When I'm working with people in the community or somebody who is pregnant, a lot of times not everyone is always aware of what these terms are, what they mean, where they're located in the body, or what function they have with pregnancy. So one thing that I like to say is just try not to assume that everyone automatically knows what you're referring to. And if needed, you can use photos or illustrations to help get the point across when talking about prevention and intervention. Which brings us to our next slide. So we talked about birth spacing a little bit, lifestyle changes, early prenatal care, all super important to reducing the risk for preterm birth. Something else that can be helpful to clients or patients is talking about certain interventions. And there are definitely more prevention methods and interventions than listed on this slide here. We could talk further about what if somebody goes into preterm labor or what those interventions may look like. But for the sake of today, we're just going to mention 17P, vaginal progesterone, and cerclage. So with 17P, the way that I describe it is that this is a progesterone medicine to help prevent preterm birth. Some people also may know it as the clinical name, hydroxyprogesterone caproate injection, which is a mouthful, or can be for some. or some also may know it by one of the brand names Makena. There's also generic versions of 17P, and if this is right for somebody, you would know because they've had both a previous preterm birth and they're currently pregnant with one baby. So not with twins, triplets, they're pregnant with one baby and they've had a previous preterm birth before. So if you know both of those things, then it's recommended as an injection. So these are shots that would be given between the weeks of 16 and 21 gestational weeks of pregnancy. It would start during those weeks. Sometimes it can vary depending on insurance or other factors, or if somebody's late to prenatal care. But ideally, it starts then and it would continue until the baby is delivered or the 37th week of pregnancy. And the great thing about 17P is that it has the potential to reduce the risk of preterm birth. So you may read different clinical studies that have varying results of that. So if you are a medical provider, super important to stay up to date with ACOG and maternal fetal medicine's recommendations on 17P, but studies have also shown it can have a significant impact. The second one, vaginal progesterone, similar to 17P because it's still progesterone as a medication. However, this is inserted vaginally and may be recommended based on short cervix or other clinical factors. The last one, cerclage. Some people have heard of this or have had this themselves and will let me know, but they don't always know that it's referred to as cerclage. So what cerclage, how I explain it to my clients is that this is a stitch that would go in the cervix and help the cervix stay closed during pregnancy. So this helps the fetus or the baby continue to develop and grow. So sometimes in groups of parents, they have varied experiences with all of these, whether it's prevention, intervention, and it's important to know that somebody may have had this and might just not know the terminology that you're using. Our next slide that talks about navigating barriers, I use this to illustrate that not all barriers that expectant parents experience are related to things that they can help change, like birth spacing and their lifestyle. And nor are the only barriers because of pain with interventions such as 17P shots. But as I started to discuss, these barriers can go far beyond and include more structural barriers that we often refer to as the social determinants of health, or the external factors that can affect health outside of the doctor's office. So we might think about socioeconomic status, education, physical environment, employment, social support networks, access to healthcare, et cetera, et cetera, et cetera. So when thinking about individual barriers somebody might experience, it could be a range of factors, right? It could be their personal experience, it could be trauma, PTSD, infant loss, pain tolerance, fears. All of that can impact when you're discussing prevention and intervention, even with preterm birth. We have systemic barriers that include racism, implicit bias, violence. So to take a moment, I want you to think about these questions with me. What are barriers or things that could impact someone trying to prevent preterm birth? So I'll repeat that one more time. What are some barriers that you think could impact somebody trying to prevent preterm birth? And you don't have to use the chat box. You can if you want to comment, but take about 30 seconds to yourself. I'm going to pause for a moment and just begin to think outside of the box. What impacts your clients or patients? And if you're done thinking about that question, I know it hasn't been 30 seconds yet, but as a provider, what could you do to make preventing preterm birth easier for your patients? What could you do to make preventing preterm birth easier for your patients? So some examples for this might include offering other options when it comes to these interventions. So example with 17P, if this is an injection that's given weekly, so we know it's a shot, it typically alternates arms. One thing that you could suggest to one of your patients if they are using 17P is to use an ice pack either before or after the injection. This could help reduce swelling, reduce pain, and also might just provide some comfort. We might also think outside the box and think of group prenatal care or centering programs. We could think about doula programs, connecting people with central intake or taking care of all of their needs, not just talking about preterm birth. So when we think about these things, it's certainly not the only methods of removing barriers for our clients or patients, because we know that many of these issues are at a systemic level, but these can help us to start thinking, how do we connect with that person individually and what are their needs outside of the time that you may have with them. The health belief model explains that if you feel the benefits of something way more than the barriers that you'll have to navigate, that you're more likely to change your behavior. So when applying this to preterm birth and patients, you might think about how do you help them understand what they can do to limit their risk? So we look at the circles on the right. When an expectant parent believes these messages, so preterm birth has negative effects, my child and I are at risk, I can minimize our risk. So talking about health, self-efficacy, it is worth the wait. Going back to that beginning image of the 37 to 39 weeks, about why should you wait until 39 weeks. These are all things, if somebody believes that will increase the likelihood that they'll want to change their behavior despite the barriers. Now, very important things to note with this. One is that somebody can do everything right, quote unquote right, or they can take all of the precautions, do all of the things that as a provider you're telling them to do, and somebody can still have a preterm birth. And I see that come up over and over and over in sessions or out in the community, right? Somebody will say, you know, either they feel guilty or that if they had only did this, maybe their baby wouldn't have been born preterm. So it's really important to remember that some parents are thinking this when you're talking to them, and that that's not always true. Sometimes you can do all of those things and preterm birth can still occur. The point is to try to minimize the risk, and also as providers and educators and policymakers, that we can start to think about removing some of the systemic barriers that then our patients and clients will not have to navigate. So racial disparities within maternal and child health. Some of those systemic barriers are racism, implicit bias, policies, and access that impact our patients and clients. Before diving in further, just to define these two terms, health disparities adversely affects groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group. So this might be religion, socioeconomic status, those social determinants of health that we talked about on the previous slide. We might also see these health disparities reflect in examples of poverty, education, nutrition, career opportunities, and advancement. And when I think about what this looks like in my community, I live and work in Essex County, New Jersey. So I think about if you're from this area or know East Orange and Glen Ridge, within a matter of minutes, you can walk between these communities. I would say drive, but it's really like 2 minutes. You can also walk from block to block, and you'll see a difference in the resources present in these towns, even though they're right next to each other. So you might also hear people speak about access to quote unquote good schools or healthcare, housing, job opportunities. This difference is showing that there's a health disparity there. When we talk about equity, we're talking about removing those obstacles that cause the differences. So we're trying to find solutions to poverty, discrimination, lack of access to all of those things about good jobs and education and housing. We're also talking about safe environments, maybe making sure that the pipes don't include lead for safe drinking water that also can impact pregnancy and birth outcomes. Many of you may have seen this photo before to illustrate equality and equity. So equality, again, being that in this image, the boxes represent the same resources being given. On the right, we see that everyone has been given resources based on their need. So we're trying to think the same way when thinking about preventing preterm birth in New Jersey. The impact of racial disparity on maternal and infant health in the United States. The impact that racial disparity has is very significant. You can see on some of the bullet points on here that Black or African American expectant parents are disproportionately impacted. So that might include that parents are 3 to 4 times more likely to have a preterm birth. They're also more likely to have a low birth weight or lose a baby to stillbirth. Black and Hispanic mothers are 2 times more likely to experience infant mortality, and the CDC estimates that up to 60% of pregnancy-related deaths are preventable for Black and African American mothers. So I'm going to pause again for 1 moment. When you see or hear these statistics, what do you feel? Some of you may not feel anything because this does not impact you. Others may have empathy, even if it doesn't impact you. And some of you may be experiencing this either yourselves or a friend or family member. So when talking about preterm birth, when talking about maternal and child health, racial disparities, equity, I want us all to remember that this can be very personal. This is not just statistics. These are real people. These are our friends, our family, our coworkers. So now bringing this back, what does preterm birth look like in New Jersey? When we look at the data for preterm birth in New Jersey, we also see that there are disparities. So in 2018, there were 9,601 preterm births in New Jersey, and this represented 9.8% of live births. In 2018, 1 in 11 babies were born preterm in New Jersey, and Black infants were nearly 2 times as likely as white infants to be born preterm between 2008 to 2018, as illustrated on the chart on the right. If we want to break this down to the county level or to the municipality level, we'll see that this data is from 2017, but the disparities would likely still look similar today. If you look all the way to the left, we see that Glen Ridge is the smallest percentage of preterm birth, 1.4%. This is well below the percentage line for the average in New Jersey. When you look all the way to the right of the chart, you'll see that Irvington, Newark, East Orange, all above that average line, and also with high preterm birth rates. So it's not by chance that the towns on the right have oftentimes less resources than the towns on the left. And this is where we see disparity and equity come into play in our community and our neighborhoods. It should also be noted that sometimes I'll get the question on this chart of why. what I get resources, I get social determinants of health, but what other factors are there? And there's not really just one answer to that, but we can think about the data and what the data says. Data tells us that the 3 municipalities on the right, so Irvington, Newark, East Orange, also have higher rates of Black women who live there. So you're thinking about the experience of racism, weathering, stress that we talked about in the beginning. We're talking about higher rates of smoking during pregnancy, late or no prenatal care, insurance status, and other possible differences when compared with these other towns on the left. So smoking is only one of the risk factors, but to highlight it for just a moment, you'll see here there are a few statistics on this slide. And smoking during pregnancy has a large impact on the health of those who are pregnant and their babies when we look at the data. When we go to the next slide, you can see a visual of how smoking during pregnancy can greatly increase the risk for preterm birth, but not only preterm birth. We see low birth weight and very low birth weight as well. This next image shows us a map of New Jersey, and what this really says is that smoking and tobacco use during pregnancy is more heavily used in southern New Jersey. However, it still does occur in northern New Jersey. To give you the example of Essex County, where PPI is located in northern New Jersey, Essex County is within the 1.2 to 2.6% range. So that means that smoking during pregnancy is much lower in the county. But again, if you were to break down this data, you would also see differences between municipalities and other areas when we look down to the county and the municipality level. In our other presentations, we also go deeper into this about how tobacco use is impacted by racism and other health disparities. Why is it more commonly used in some of those towns rather than other areas? And it's also important on this slide to know that Black and white women are more likely to smoke during pregnancy than are Asian, Hispanic, Latinx, or Indigenous women. Compared to the rest of the United States, the smoking rate in New Jersey is actually about half the nationwide rate, but it still has an impact on those who smoke, as illustrated on the previous slide. All right, so that brings us to our initiative, the Prematurity Prevention Initiative. What I want to share with you all are some of the strategies that we use to try to prevent preterm birth. Hopefully some of these you may think that you can incorporate into your own practice or inspire you if you are not from New Jersey to use elsewhere. On this slide, there's a few pictures. These are real pictures of our initiative. So you'll see up top Dr. Ruffin speaking with a mom and a baby. You'll see on the bottom left, this is some of the PPI staff meeting with other stakeholders to talk about data and sharing information in the state. And on the bottom right, this is actually a mix of our two programs at the partnership. It's the Prematurity Prevention Initiative and also our PAP program, which is our perinatal addiction program. We spoke with nurses in Hudson County, so this was Harrison, New Jersey, and we met with nursing students and talked to them about different topics related to pregnancy and birth outcomes. They were very engaged, very fun to talk to, and had a lot of information to share themselves as well. Some of the strategies that we use at the Prematurity Prevention Initiative are engagement, awareness, collaboration, education, and the sharing of resources. One of our goals with engagement is to increase community awareness, collaborate and align with key stakeholders. So that may be some of you on this call today. I know I've worked with a lot of people in Northern New Jersey that either work for a hospital, a birthing center, an OBGYN clinic. It could be other community providers on this call as well. Maybe you're even a parent listening in. And what we really try to do is engage with the community and make sure that we're hearing feedback from you all as well. The third one, disseminate use of a client engagement tool. I'm going to speak a little bit more about that at the end, but it's going to be on a resource sheet that I can email to you. It's a tool that you can use with clients who are pregnant, and it will send positive information about pregnancy. So it might say, hey, you're doing great, keep going. It might say, here's a link for you to click while you're in the waiting room, waiting for your prenatal appointment. And it's all supposed to be uplifting, engaging, and sometimes even fun to get information rather than somebody just speaking to you all of the time. This is something that you can use to empower yourself and receive information. The fourth one is professional and clinical trainings available on-site and online. So you're on a online training right now. Before, we would also go out to different sites, and I would make presentations that are interactive. We would talk about preventing preterm birth and all of these things as well. Our next goal is awareness. So our awareness strategy aims to expand the goal of preventing preterm birth, eliminating racial disparities, and to further reach Black communities across the state. Some of the ways we do this are by raising awareness that PPI provides streamlined access to effective medication. So when it's saying effective medication here, one of those medications are 17P. So before we had, if you had clients who were on 17P, but there was a gap in insurance, or at the hospital if charity care or something would not cover the cost, then we would have supplemental funding to offer that to patients who would need it. The second one, PPI strives to form partnerships. So again, just really working with community groups, stakeholders. We try to reach out to sororities, fraternities, faith-based organizations. If you've never heard of us before, I'll give my email at the end. You can reach out to me, but really just helping us all to raise awareness of preterm birth, that this is a serious topic in the state of New Jersey, also the United States as a whole. But really just trying to share that accurate and up-to-date information with the people who need it, which is really everyone, right? Because going back to our goal, we all have a role in preventing preterm birth. Just a quick note, we also work with some advocacy groups, so spreading awareness through NAACP. We have a task force, and we reach out to people through that way as well. We also have social media. If you want to follow us at NJ Preterm, we're available on Facebook, Instagram, and Twitter. Collaboration. So some of our goals really overlap with each other, but collaboration really speaks to our dynamic leadership team. We have a team of New Jersey professionals. This includes OBGYN, maternal fetal medicine practitioners. They're helping us to create lasting changes in healthcare. The leadership team also addresses challenging topics in maternal healthcare with a focus on equity. And they also bring together leadership from both Northern and Southern New Jersey. So we're working together on this initiative and really making sure that we're hitting various areas of the state. The leaders not only offer their medical expertise, but they help other professionals within PPI, such as myself as education coordinator. They help guide what the clinical recommendations are for the work that somebody like me would do out in the community and the information that we are sharing and passing on. We also connect with local social services and community organizations such as Central Intake, WIC, OBGYN clinics, doctors, nurses, New Jersey Department of Health, medical school professors, and we want to expand our work and continue to create new events, resources, and connections. And finally, the Moms Quit Connection and Healthy Women, Healthy Families are two programs that we're aligned with, and they help us to reach the various communities with resources such as smoking cessation and home visiting programs. Our education goal helps us to offer free education and training to medical professionals, organizations, agencies. If you want something tailored specifically to your agency, feel free to email us and we can help decide what resources might be right for you. The educational presentations and resources are available whether you're a sorority or fraternity, a medical facility, faith-based organization. And what the sessions usually highlight are free preventative care options available to expectant parents, but they also discuss the clinical needs of parents with a history of preterm birth and address how to navigate healthcare barriers. This image here is of Dr. Ruffin. She is part of our PPI leadership team. She's also a medical professional in Southern New Jersey, and she often shares clinical information with patients about preterm birth and 17P. So the image here is actually a video that Dr. Ruffin has created, and it's one that we often share with patients or clients so they can get an understanding of what 17 might be. And our last goal or strategy, which is resources. This is one of my favorite to share because I really enjoy practical applied things that can be given and be helpful as far as information goes, or even tools to help prevent preterm birth. So on this slide, you'll see funding for 17P injections. Again, if you're interested in that for your patients, or you know somebody who is uninsured, underinsured, or there's a gap of insurance, on the resource sheet, I'll have your emails. I'll send that out to you for how you can access that. The second one, the client engagement tool. This is also going to be on that resource sheet. The client engagement tool is that texting service that the patient or client could use to text and get those happy, fun, interactive messages, both about 17P and preventing preterm birth and healthy pregnancy. The perinatal risk assessment, this is through Family Health Initiative. So this offers free perinatal risk assessment, the PRA, and this is training to New Jersey medical providers. The PRA is a clinically validated tool to screen pregnant women for tobacco, substance abuse, illicit drugs, depression, and violence. This tool also can help track 17P therapy and connects mothers to services such as Moms Quit Connection. And as of May, some of you may know this, May 2020, all providers in New Jersey were required by law to start implementing this screening tool. So you can access PRA Plus information by going on the website, praspec.org, or the email will also be on that resource sheet after today's session. Moms Quit Connection for families. They provide free one-on-one counseling for pregnant and postpartum women, moms, dads, family members, really anyone in the family who would like to quit smoking and help avoid some of the outcomes that can happen from smoking during pregnancy. But a trained quit coach could help answer any smoking related questions also for your patients or clients. So they can visit momsquit.com for more information. And the last one on this slide, NJ Access Link. This is a transportation service. So if we think back to the strategy of using 17P, if somebody has had a previous preterm birth, one of the barriers that a lot of patients encounter is getting to the appointment. So we might think about if it's a weekly injection that is needed, they're not only navigating who's going to watch their other children if they have any, but how to just navigate getting to the appointment sometimes if it's you know, either a high-risk pregnancy, or if you don't have a car, or if you're taking public transportation. Additional barriers with COVID-19 right now. NJ Access Link is a resource that could be used to help pick them up from their house and bring them to where their medical appointment will be. And again, there's going to be more information on that resource sheet. So if transportation is a barrier for your clients, you will have that information. PPI is not the only program in the state of New Jersey addressing preterm birth. So the governor and First Lady, Tammy Murphy, have been really committed to ending health disparities in New Jersey. They have the Nurture New Jersey Awareness Campaign. They do a lot that are listed here: the Summit, Family Festival, social media, NJ Access Link. And something that some of you may have seen more recently is since we've been online and many working from home or viewing webinars and educational activities from Facebook and social media, they've had Q&A sessions with different clinical providers or educators in our state that address questions that pertain to pregnancy and maternal and child health. So what are some actions that we can take? There's a lot listed here, but if you take a look at the slide, you can think about what might be good for your clinic, your hospital, your agency. Just to point out a couple on here, you might want to further educate staff. So if you really found some of this information informative or would want other data and information, you can give us a call or email us to bring us in. We can promote implicit bias training in health systems, share family health initiative services and resources with patients, and advocate for more maternal health services such as doulas, breastfeeding, midwives, etc. Just to review, messages for patients before pregnancy might include discussing family planning with their partner, identifying their support system, especially now. What does that look like with COVID-19 and different rules in hospitals and policies about who can come to the prenatal appointments or the birth? They may want to choose something virtual if that's something they have access to. Virtual support system. I know the partnership, we also have virtual support groups through our PPD or perinatal mood disorder program. That's also on our website. Scheduling a preconception appointment to discuss various topics. Messages for your patients during pregnancy might include beginning prenatal care early in the first trimester. It might include calling a medical provider with any concerns or questions, knowing that you can actually change your medical provider if the one you have is not working for you, and communicating your needs with your support system. Again, continuing to monitor some of this: signs of preterm labor, nutrition, STI prevention, stress, environmental and social factors. And it doesn't end there. So after pregnancy, still connecting with the support group, allowing your support system to help, attending and follow-up appointments with the medical provider. These are all messages that we can all give. Some questions are listed here about what your patients or clients can ask their medical provider about preventing preterm birth. So maybe they want to know what some of their risk factors are. They might want to know some of the signs and symptoms of preterm labor. What do they do if they experience preterm labor? Who do they call? How do they get in contact? And how do they get connected? and maybe they've heard of 17P or another intervention, what is going to be right for their care. So taking a moment just to reflect and think about what would you share with your patients or clients about the following: preterm birth, the resources available, 17P, navigating barriers. What are some of the things that we all could share with somebody we know? The take-home points I would like you to remember are that Black infant and maternal mortality is in a state of crisis. Health and racial disparities impact maternal and child outcomes. And in New Jersey, Black women are nearly twice as likely to experience a pregnancy-related death than their white counterparts. Black infants are nearly 2 times as likely as white infants to be born preterm in New Jersey. We all have a role in improving outcomes for Black maternal and infant health. To learn more, you can visit American College of Obstetrics and Gynecology, ACOG's website, Center for Disease Control, CDC, and March of Dimes for more information on preventing preterm birth. I want to thank you all so much for attending this webinar and listening to this information. If you enjoyed this and would like more or have a question regarding the resources, you can contact me at my email, kmial@partnershipmch.org, or by phone, 973-268-2280, extension 109. Please follow us on social media. We're on Facebook, Instagram, Twitter at NJ Preterm. On LinkedIn, you can type in Prematurity Prevention Initiative. Friend us there. We share lots of information and are trying to share more on social media. So thank you. And if you want to know more about our partnership programs, www.partnershipmch.org. We have lots of information for you there. Thank you so much. So Amy, I'm not sure if anyone had any questions in the chat box, if we wanted to take some of those now.
Yes, thank you, Kaci. That was really terrific.
Thank you.
The first question we have, I'm interested in receiving the COVID-19 Go kits you mentioned. Can you repeat how I can apply for those kits?
Sure. So COVID-19 Go kits, that's one of the resources I didn't talk too much about, but these are kits that are available for qualifying prenatal providers. If you are a qualifying prenatal provider, what you can do is visit the Prematurity Prevention Initiative's website at njpreterm.org. It's going to give you a link for the form, and it's going to say COVID-19 Go Kit. So what these kits have, they have different blood pressure tools, they have different screening, there's a water bottle, there's things that you might find helpful to share with your patients or clients. And right now we're giving those out for free, but it's a limit of 25 kits per qualifying entity. So again, just go to njpreterm.org. There's more information about what is in that kit. And if you're a qualifying medical provider, please sign up and apply.
Thank you. This is a question from Andrea. What are the variables that make pregnancy or related deaths 60% preventable for African American mothers?
So that's a very good question. When we talk about that statistic, the 60% are preventable for Black or African American mothers, that's talking about maternal mortality. So when we think about the factors for why there's a crisis for Black infant and maternal mortality right now, the main factor is racism, implicit bias, but some preventable factors, just to give some examples, it might be listening to the patient. There's some examples of moms who have given birth and shared their story, such as Serena Williams, Allison Felix. They have both shared that after giving birth, they were not listened to. So that might look like saying that a Black woman telling their medical physician that they are in pain or something's not right in their body. That's one of the main things that we can change this culture of, that there are many myths surrounding what Black birthing persons experience, and learning those are one way that you can prevent maternal mortality. But I would say we do have a program, the FEMUR program at the partnership, which is the Fetal Infant Mortality Review that focuses on infant mortality. And that might be a good resource as well that could be found on our website. And we can always give you more information about that later as well.
And we have another question from Kara. If a pregnant person is smoking while pregnant, do you have any advice on how a nurse could communicate therapeutically the benefits of not smoking while still validating the person's feelings and not making them feel judged?
Absolutely. It's another tough question, right? Because we're thinking about what that person's culture might be or what their experience during pregnancy has been thus far. We don't know. So I think anytime that somebody shares something with you that they're struggling with or they want to change, just acknowledging that that's a real experience. That's a place to start, right? Like, yeah, I know it might be hard to stop smoking, or that, you know, just reflect back to them whatever the sentiment was that they shared with you. And then you can always, if you don't, if after that you just want to share a resource with them, that's one way you can do it as well. So you can always say, hey, if you're interested in learning more about quitting smoking, here's Mom's Quit Connection. You can give them a call to have a trained coach speak with you more. And that way, if you don't feel comfortable answering that question or affirming them right there, that you can pass them on to somebody who is trained to have that conversation.
And I think we have time for one more question. Thank you for this information and webinar. This was very helpful. Do you have any more events I can sign up for?
We do. Thank you so much for asking. I'm very excited. You know, this is only one of the presentations PPI has to share with you in the partnership, but next week we're actually having a Mom's Chat and Chew. This is a collaboration of different partnership programs. We're going to be sharing information with expectant parents or new parents about, we have different topics: breastfeeding, preterm birth, our Trusted Links program, how people can get involved in that. So if you have a patient or client that you think might benefit from attending something like that, then please sign up for our Mom's Chat and Chew. It's on July 15th. 2 to 4 p.m. I believe is the time, and you can sign up on the website. We're also going to have a speaker series coming up this summer, so keep an eye out for advertising about that. It's going to be a mix for professionals, clients, educators, for everybody. And in November, we also hope to share more information for Prematurity Prevention Month.
Great. Well, I appreciate you joining us here today, Kaci, and I'd also like to shout out our thanks to Laura Hall, who's handling the technical back end of the program. We appreciate everybody who has joined us today, and just a reminder that in about an hour, you'll receive an email with a link to a post-program evaluation. Please complete the evaluation in order to give us feedback and to receive a certificate. Certificates of completion will be sent via an email, and they'll be sent via the email you supply in the evaluation. So please make sure that there are no typos in that. And you should receive your certificate within 1 week. A calendar of the partnership's upcoming virtual programs can be found on our website at www.partnershipmch.org under the Professional Education tab. We also offer on-demand recordings of many of our programs, which are listed there as well. Next week's program will be reducing the risk of sudden unexpected infant death through safe infant sleep practices. We hope you can join us. Have a good day.